What's up, Ninja Nerds? In this video today, we're going to be talking about pheochromocytoma. Before we get started, if you guys like this video, it makes sense to you, it really helps you, please support us. How can you support us, you ask? Please hit that like button, comment down in the comment section, and please subscribe. Also, if you guys get a chance, I think it would really benefit you to check out the notes and illustrations that we have on our website. Click in the description box and below, there's a link there, and that'll take you to our website. We got some awesome notes and illustrations. But pheochromocytoma, heck of a name, right? With this particular disease, the primary pathophysiology, or the question behind this, is that there is an excess of adrenal medulla hormones. So in the diseases that we talked about with Cushing's, or that we talked about with hyperaldosteronism, that was a problem where the adrenal cortex was pumping out too much hormones, such as cortisol or aldosterone. In this particular disease, the pheochromocytoma, it's the medulla portion that is the one that's pumping out large amounts of catecholamines. That's the problem here. So this sucker here is just pumping out these catecholamines into the blood. And so there's a massive amount of catecholamines. Which type of catecholamines, you ask? The primary ones are going to be epinephrine, norepinephrine, and to a small degree, very small degree, dopamine. These are going to be the primary molecules that the adrenal medulla is pumping out in very large amounts. These, or what we refer to as catecholamines, basically they're derived from what's called a catechol ring. So these are called catecholamines. Now, the ones that I really want you to spend your time remembering is epinephrine and norepinephrine. Those are the primary ones that are super elevated. So epinephrine and norepinephrine are super elevated. If you get a little bit of time to remember the other one, dopamine might be in small amounts as well. Now, this is the primary pathophysiology. The adrenal medulla, for some reason, and we'll talk about what that reason is generating large secretion of epinephrine, norepinephrine, dopamine. Now, the question that you may ask is what's the cause? The causes behind someone developing this particular adrenal medulla kind of hypersecretion of hormones is really interesting. Oftentimes, there is some type of tumor here. And this is usually very interesting. So if we look at the adrenal medulla, it's actually made up of something called chromaffin cells. So chromaffin cells. And these are derived from what's called your neural crest cells. So they're derived from what's called your neural crest cells. These are super interesting. So what happens is, in this disease, pheochromocytoma, there is a tumor that's involving the adrenal medulla, the chromaffin cells that are derived from neural crest cells. The other thing that's really interesting is that usually this tumor is unilateral, okay? Usually it's unilateral. The second thing is that it's often commonly occurring in adults, usually third generation of life, so usually more commonly involving adults. The other thing is that with this particular condition, it's oftentimes idiopathic. We don't know why it happens. It's kind of a sporadic type of problem. So it's oftentimes idiopathic. And these are really big things to remember. So one of the big things to remember is that there is some type of tumor that is involving the adrenal medulla primarily. So it's involving the adrenal medulla, involving particularly the chromaffin cells that were derived from neural crest cells. It's usually unilateral, occurring in adults, and idiopathic. Now, the question then comes, okay, there's this tumor. It's the one that's responsible for pumping out large amounts of these catecholamines, yeah? Well, the question that I have is what's the trigger? What's the true trigger behind causing these to start pumping out catecholamines? Because it doesn't happen all the time. One of the big things to remember is that this catecholamines, this surge that they have, is usually paroxysmal, meaning it does not occur every single time continuously. It's certain bursts. So now the question is what are those paroxysmal triggers? That's what you need to be asking yourself. So what are these paroxysmal triggers? And this is high yield, my friends. You need to know this. The particular triggers that I want you to remember is, one is going to be what's called monoamine oxidase inhibitors. We use these in depression. We use these in Parkinson's disease to be able to basically do what? Monoamine oxidase inhibitors naturally they break down catecholamines. So in other words, what would these naturally do? Monoamine oxidase inhibitors, what they do is, generally, monoamine oxidases are responsible for taking things like norepinephrine, epinephrine, and dopamine, and they break them down. So they get broken down. Now imagine I give someone a monoamine oxidase inhibitor. If I give them a monoamine oxidase inhibitor, I'm going to inhibit the monoamine oxidases. I will prevent the breakdown of norepinephrine, epinephrine, and dopamine, and the levels will shoot through the roof. So now they have just a little bit extra, enough to be able to cause these paroxysmal changes. The second thing that I want you guys to remember is tyramine. Tyramine is an interesting kind of like amino acid. And we find this in like cheese. We find this in red wine. And you can even find this in chocolate. Now, what happens is tyramine's really interesting because normally what happens is if you were to, for example, let's say, for example here, I have a neuron and here it's gonna have this like vesicle here that releases norepinephrine, right? Naturally what happens is there's a transporter here that's supposed to take the norepinephrine and generally you can have it reuptaken, right? Well, there's another thing that you can do. You can take tyramine and tyramine can actually kind of use this transporter and what it can do is it can actually pump out norepinephrine. And so what you can do is you can increase the release of norepinephrine. And so that's one of the downsides about this particular thing. And you know what's even worse is if tyramine is taken with a monoamine oxidase inhibitor, it enhances the effect. So you can see some really bad problems with it. So again, big thing, monoamine oxidase inhibitors, don't take them because they increase norepinephrine, epinephrine. Tyramine also will increase the release of norepinephrine. So that's another one that you want to remember. The third particular thing that you want to also watch out for is going to be any type of abdominal manipulation. So anytime somebody is experiencing any abdominal manipulation, what do I mean? You're getting a procedure, a surgery. So if you're getting, let's say you're having a surgery done. And while you're in there, maybe you're doing a surgery in the abdomen, and you just so happen to push or squeeze on the adrenal gland, and you milk some of the epinephrine, norepinephrine out of that actual gland. That's enough to actually cause a potential person to go into a pheochromocytomic event, like at a crisis. So these are the big things that I really want you to remember. So watch out for if they take monoamine oxidase inhibitors, tyramine-rich foods, or have any sort of abdominal manipulation. This can cause paroxysmal events of catecholamine release, especially if the patient has a unilateral adrenal medulla tumor involving the chromaffin cells that are derived from neurocrest cells. Now there's one particular thing that we got to talk about. There's this exception rule that actually comes into play that you may see on your exams, and I want you guys to be able to recognize it. I don't want you guys to miss it. So if this comes up, oftentimes, 90% of the time, it's going to be tumors involving your adrenal medulla, particularly the chromaffin cells, unilateral, adults, and idiopathic. 10% of the time, it will be, so 10% of the time, it can be familial, meaning it's genetic. So that basically essentially means there's a genetic component involved here. And these genetic components, there's 3 particular genetic conditions that I want you guys to be familiar of. One is called MEN2A and MEN2B. This is called multiple endocrine neoplasia, 2A and 2B. 2A primarily involves, it causes hyperparathyroidism, and it also can cause another particular problem such as pheochromocytoma and even problems particularly with the medullary thyroid cancer. Whereas 2B usually is going to be a pheochromocytoma, they also can have problems with their thyroid, and then the other issues, they have like what's called a marfanoid body habitus and mucosal neuromas. But the big thing is, remember, this particular gene can be associated in 10% of cases for pheochromocytoma. Another one is neurofibromatosis type 1. And another one is called von Hippel-Lindau. So if any of these potentially are a possibility, if there's any mutation involving any of these genes, this can lead to tumor development within the adrenal medulla. Now, the way that it does this is that usually neurofibromatosis type 1 and von Hippel-Lindau are what's called tumor suppressor genes. So if you cause a mutation where you lose the tumor suppressor gene. Now the actual cells can proliferate uncontrollably. And then MEN2A and MEN2B are what's called proto-oncogenes. And if you accelerate or increase the activity of the proto-oncogenes or inhibit the tumor suppressor genes, you basically increase the risk of forming a big honkin' tumor. And that's the pathophysiology behind that, right? But this is only in 10% of cases, so you likely have to have some type of family history. Okay, the next component here that we have to talk about is that not only is 10% familial, but 10% is usually bilateral. 10% is in children. 10% of these are malignant. So you see, it's just the opposite of what's usually normal. Oftentimes it's idiopathic. Oftentimes it's unilateral. Oftentimes it's in adults. Oftentimes it's benign. And then the last thing is 10% can be extra adrenal, meaning that it's not inside of the adrenal medulla. It's involving something else. And this is a weird stinking thing. So here's your adrenal, here's your adrenal, here's your aorta, right? So here's your aorta. There's this kind of like ganglia that's located near the aorta. They're called, and this can form something called paragangliomas. But this structure here is called the organ of Zuckerkandl. And this can potentially be a site of epinephrine and norepinephrine excessive production or catecholamine release. And so these are the things that you want to be wary of, okay? So to quickly recap the basic concepts that we're going with pheochromocytoma. It is a tumor. 90% of the time, it is a tumor that's involving the adrenal medulla, particularly the chromaffin cells that are derived from neurocrest cells. It's usually involving primarily one adrenal medulla. It's usually benign, it's usually idiopathic, and usually occurring in adults. And what happens is there's a tumor there that will intermittently pop out tons of catecholamines such as epinephrine, norepinephrine, and to some degree, dopamine. What's the triggers behind this? Monoamine oxidase inhibitors and tyramine. These are two particular things that will increase norepinephrine and epinephrine amounts. All right? The other concept that you have to remember is that sometimes there's what's called the rule of tens. So if it doesn't follow this perfectly, 10% of the time it can be familial, where you want to remember these particular genes. There's oftentimes a family history. Look for a family history in the clinical vignette. And then if it's not unilateral, if there's a chance it's bilateral, it's in children, it's malignant, or it's extra adrenal. Again, these are other potential possibilities. The one extra adrenal site that you have to associate this with is the organ of Zuckerkandl, usually near the aorta. These are called paragangliomas oftentimes. All right, so now what we gotta do is, we have a patient with an adrenal medulla tumor or an extra adrenal medullary tumor, and they're pumping out catecholamines. What would this look like in a patient? All right, my friends, so now we have an adrenal medulla tumor, 90% of the time, chromaffin cells, right? There's a tumor involved in that, and they're pumping out epinephrine, norepinephrine, some degree dopamine, but they're pumping these puppies out, usually triggered by monoamine oxidase inhibitors or tyramine or by abdominal manipulation of some type. In the 10% of cases, it could be some type of extra adrenal tumor, like the organ of Zuckerkandl near the aortic bifurcation, the paraganglioma one. It could, again, potentially be familial, so some type of genetic relationship that there could be associated with this, such as MEN2A, von Hippel-Lindau, or neurofibromatosis type 1. But generally what happens is once they start pumping out these massive amounts of catecholamines, what do they do to the body? That's the question, right? So what would the patient look like? So when these catecholamines release, what they do is they act on particular receptors. So in the cardiovascular system, we have the beta-1 adrenergic receptor. And these are present on the nodal cells, and they're also present on the contractile portion of the heart. Now, if they work here, what they're gonna do is, on the nodal cells, they're going to increase the heart rate. Now your heart's gonna be firing super fast. When your heart fires super fast, this is gonna cause tachycardia. That's what we call that, tachycardia. Now, one of the problems is tachycardia is the vital sign. So we'll see that whenever we do vitals. But one of the problems is the subjective feeling of tachycardia that sometimes can produce something called palpitations. So that's another particular finding that you may see. They may have palpitations associated with their tachycardia. And that's due to excessive stimulation of the beta-1 adrenergic receptors, because you got epinephrine and norepinephrine surging through these and just binding like a son of a gun to these beta-1 receptors. Okay, what else? They also bind to the beta-1 receptors on the contractile portion of the heart. So now you're going to get an increase in your stroke volume. They're going to contract more. Cardiac output's going to go up a little bit more. So cardiac output will go up more. Now, two things can happen out of this. If you're contracting your heart a ton, one of the things is that this definitely can shoot up your blood pressure. So this may lead to hypertension. So you may associate this with hypertension. Pretty significant hypertension, I may add as well. But the other thing is when your heart is contracting so much and so intensely, it consumes tons of oxygen. And whenever you consume tons of oxygen, it actually makes the heart have to work really, really hard. And so if you don't have enough supply to it, that can actually cause ischemia and angina. We'll talk about that in just a second, but I want you to remember that. The other thing here is that the norepinephrine and epinephrine that are surging through your bloodstream because of that adrenal medulla tumor just pumping them out into the blood, what happens is if the norepinephrine or epinephrine, which are the big ones that I want you to remember, bind on to this other adrenergic receptor. This is your alpha-1 adrenergic receptor. So now you got these things and they're gonna hyperstimulate your alpha-1 adrenergic receptors on your blood vessels. When they bind onto them, they're gonna squeeze that vessel like a mofo. When it squeezes it, it's gonna cause an intense vasoconstriction, which is gonna increase your systemic vascular resistance. And that is also going to shoot up your blood pressure big time. When you shoot up the blood pressure big time, it's gonna precipitate a hypertensive event. So oftentimes, some of the things that you can already associate this with is palpitations, very uncomfortable. Tachycardia, so your heart rate's gonna be going pretty quick. And then hypertension, and this is usually a hypertension that's like super, super refractory. In other words, you put them on antihypertensives and they don't actually improve. And it's paroxysmal, it comes on every now and then whenever they have red wine, cheese, chocolate, or they take a monoamine oxidase inhibitor for their depression or Parkinson's disease, or it could also be due to abdominal manipulation, sometimes even like abdominal massage or surgical procedure. There's one more if you want to remember. Beta blockers are also a pretty particular strong stimulus for that process too, but we'll talk about that a little bit later with treatment and explain it more. All right, but anyway, these are the three things we've seen so far. We're gonna add one more on, okay? With hypertension, when high blood pressure is really, really high, a couple different things can happen. One is this can precipitate what's called a hypertensive crisis. So if you have a hypertensive crisis, the blood pressure starts shooting up to what's greater than 180 over 120. The problem is that you can start experiencing target organ damage. So you can actually start damaging tissue. And so what starts happening is you can actually start seeing target organ damage. What do I mean by this? In other words, I may start seeing stress on the brain. The pressure's so high in the brain that it can actually cause strokes. Maybe this is an ischemic stroke, maybe this is a bleed. So we can see again, target organ damage. I'm gonna put TOD. The other thing I can see is potentially renal injury. So you may see acute renal failure. You can also see damage onto the heart, a lot of stress and demand on the heart. So this could lead to an acute myocardial infarction. And these are some potential things that could really cause a lot of issues. It could even affect the eyes and cause like vision problems. But the big thing that I want you to remember is that sometimes not only can it do this, but it can also precipitate other things. So whenever your blood pressure is super high, watch out for things like a headache. This is a really, really common one. They can have some pretty intense headaches. Or what happens is when your blood pressure is so high, it puts such a stress on your heart. So your blood pressure is so high, it can increase your oxygen demand on the heart. And when you increase the oxygen demand on the heart, this can definitely produce angina. And so other things that you really want to watch out for with this hypertension, especially because it can get really bad, is watch out for angina, watch out for headaches, and watch out for hypertensive crises that can potentially lead to an emergency, a hypertensive emergency, where the patient can develop target organ damage. If they don't develop target organ damage, then we would call that a hypertensive urgency. It's just the BP's high. These are things that I really want you to remember. Okay. The next concept here is with the cutaneous vessels. Believe it or not, this kind of goes along with the cardiovascular system itself. But whenever epinephrine and norepinephrine are released, so again, you have your adrenal medulla just pumping out these catecholamines. Whenever epinephrine and norepinephrine bind on to these vessels, so here's going to be your dermal blood vessels. These control blood flow to the skin. right? So they give kind of the hue to the skin, help with kind of heat conduction and helping to regulate your body temperature. But whenever you have these alpha-1 adrenergic receptors that are present here, whenever that dang norepinephrine, epinephrine bind to these puppies, you know what they're gonna do? They're gonna cause an intense vasoconstrictive response. So what they're gonna do is they're gonna cause an increase in the systemic vascular resistance, which is going to decrease blood flow. And that's gonna lead to pallor. You're not gonna have as much blood flowing through these arteries because they're gonna be so clamped down. If there's not as much blood flow going through these arteries, it's not gonna radiate that reddish hue to the skin. And one of the big things is they can develop a pallor type of look. All right, so far we've had an excessive sympathetic overdrive to the heart and the blood vessels, especially the cutaneous vessels that have precipitated palpitations, tachycardia, hypertension, with worst case scenario, a crisis. If it's urgency, it's just high BP. If it's a target organ damage, now you're experiencing hypertensive emergency. Watch out for things such as stroke, acute renal failure, acute myocardial infarction, and sometimes that may precipitate with a headache or angina, chest pain. Okay, let's come down now and let's talk about the next component here, which is going to be, what about that liver? What about that good old liver causing some problems here? So if the liver were to cause some problems to us with respect to the epinephrine and norepinephrine, now you got all this epinephrine and norepinephrine binding onto your beta-2 adrenergic receptors that are present on the liver. We're going to hyperstimulate them, baby. If we hyperstimulate them, we are going to increase glycogenolysis and gluconeogenesis. Every time when you have a sympathetic event, think about it. You want your blood pressure to be high. You want your heart rate to be high. You want to shunt blood flow away from non-vital organs like your skin and put it into your organs that like your muscles. And all of these things are natural fight or flight events. This is literally what these patients are going through, then these paroxysmal or kind of like intermittent events. They're going into a fight or fight kind of crisis event where their blood pressure shoots up, their heart rate shoots up, their cutaneous vessels vasoconstrict, and then you want a lot of glucose to be in your bloodstream so that you can fuel those muscles during the fight or flight event. So that's another thing. So the liver will start breaking down glycogen and converting things like amino acids and non-carbohydrate molecules into glucose. So it'll help to promote hyperglycemia. So it'll increase your blood glucose levels. It will increase your blood glucose levels. Now, this is because it's inducing something called gluconeogenesis, or it's also precipitating something called glycogenolysis. It's breaking down glycogen into glucose, or it's forming new glucose via non-carbohydrate molecules, amino acids, odd-chain fatty acids, glycerol, things to that effect. Okay, so far we've had hyperglycemia, the effects of high blood pressure, headache, angina, the effects of high heart rate palpitations and associated tachycardia and hypertension, pallor due to cutaneous vessel vasoconstriction. What about the nervous system? There may be, unsure, but there may be some type of sympathetic effect on your limbic system. Your limbic system controls your emotions, right, my friends? And it's very, very closely related to your sympathetic nervous system. So what you're doing is you are hyperstimulating your limbic system that controls your emotions and your memories. And what happens is you become very, very anxious. So they have a very intense anxiety, and sometimes people even say that they feel like they're going to die. They feel like a sense of impending doom. So these are things to watch out for. Now this other mechanism is really interesting. How it exactly is unsure, but maybe this increase in norepinephrine, this increase in epinephrine may have a profound effect on stimulating your sympathetic outflow. So maybe you have an increase in your sympathetic outflow. But here's the one weird kind of thing that happens. There's one particular type of target organ that when you release these types of molecules, they are not catecholamines. This is acetylcholine. And acetylcholine will actually bind onto these muscarinic receptors when your sympathetic nervous system is activated, believe it or not, and trigger you to produce a lot of sweat. So they will have perspiration and pretty significant amounts of it, my friend. So they will have perspiration as a result of increased sympathetic outflow. It's just important to remember that since the sweat glands are innervated by acetylcholine and there's muscarinic receptors, it's not norepinephrine, epinephrine that's directly affecting the glands. It's maybe indirectly by enhancing the sympathetic nervous system. So far we have anxiety, we have perspiration. There's one more thing. This one's actually kind of a cool one. There is beta 2 adrenergic receptors that are present on these things called muscle spindles. Muscle spindles. Now imagine that you load these muscle spindles up with norepinephrine and epinephrine. You're going to hyperstimulate these muscle spindles. It's going to increase the actual afferent signals to the spinal cord, increase the efferent signals out to the muscle, and cause the muscle to contract intensely. And you know what this precipitates? This precipitates tremors. Oh my gosh, there's a lot of problems that are going on with these patients. So in a patient who has pheochromocytoma, they have a massive catecholamine surge that can precipitate increase in heart rate, tachycardia, palpitations, increase in blood pressure, so hypertension, refractory hypertension, that sometimes can cause target organ damage, stroke. It can cause potentially acute myocardial infarction, acute renal failure. It may precipitate with headaches and angina, chest pain. It may also cause hyperglycemia. It may also cause pallor due to cutaneous vessel vasoconstriction. It may cause anxiety and a sense of pendic doom, sense of limbic system activation. It may also cause perspiration via a weird mechanism. And it may also precipitate tremors due to increased muscle spindle activation. Now what we need to do is we have a patient who we think has pheochromocytoma. How do we work them up and diagnose it? All right, my friends, so we think we know we have a patient who has pheochromocytoma. If we think this, again, it's suspecting that it's an adrenal medulla tumor that's pumping out massive amounts of catecholamines, usually unilateral, usually in adults, usually benign, and again, usually idiopathic. In the rule of tens, though, there's 10% of cases that can be malignant, can be bilateral, can be in children, can be extra-adrenal, and can be familial, such as von Hippel-Lindau neurofibromatosis type 1, or could also be MIN2A, MIN2B. We also want to think about the triggers. What would cause a patient to develop these paroxysmal events? Monoamine oxidase inhibitors, tyramine, abdominal manipulation, and if you have that extra time, beta blockers. If we see this, what are the particular things that will really cue me off to do some screening tests? If I see the 5P, so if you forgot everything, don't worry, I got your back. Look for, first thing is pressure. So pressure is going to be the first one. And what do I mean by this? I mean high blood pressure. This is usually the one big factor, so high blood pressure. The second one is pain, okay? So they have pressure or they have some type of pain. And that pain could be headaches, it could be angina, right? So this is usually due to some type of high blood pressure problem. So it could be some type of headache or it could be angina. The other ones is it could be palpitations. This is due to the tachycardia. So look for palpitations. So palpitations is usually secondary to the tachycardic type of patient. Okay, what else? Pallor, cutaneous vessel vasoconstriction. Cutaneous vessel vasoconstriction is another one. So this is usually due to pallor, and we'll put vasoconstriction. Of which ones? The cutaneous vessels. You know the big one? Perspiration. Perspiration is another one. So if you see this, if the patient is pale, having palpitations, having any type of headache or angina, having any type of pressure problems, and they also have, again, perspiration, such as they're sweating a lot due to the cutaneous supply of sympathetic overflow. But again, remember, it's not norepinephrine, epinephrine that's directly affecting the glands, it's indirectly through increased sympathetic outflow. But there's only one exception where you don't release norepinephrine from a postganglionic motor neuron, and that is usually the cutaneous supply to glands. That's where you release acetylcholine and they act on the muscarinic receptors. If you see this in an adult, okay, you should start thinking about an adrenal medulla tumor causing pheochromocytoma. So then you go to the next test. If this occurs, the next thing is we're gonna go here. We're gonna now move into the screening tests. We can do two tests. This one is less sensitive. This one has higher sensitivity. So I would pick this one for my high risk patients, which ones I have a high suspicion. So my high risk patients, I'd pick this one for my low risk patients, the ones I have a kind kind of a lower suspicion for. The basic concept behind both of these is they're both really the same. You take something like tyrosine, right? So this is kind of going over the pathway. Tyrosine we know gets converted into something called dopa. Then dopa gets converted into something called dopamine. Then dopamine gets converted to something called norepinephrine. And then norepinephrine gets converted to something called epinephrine. And this is via an enzyme, the PNMT enzyme, which is obviously can be affected by cortisol, right? Now, what happens is, this is the normal type of pathway, and there's many different enzymes that are involved in this process. The big particular thing here is that sometimes when you get to norepinephrine and epinephrine, they can have their breakdown products, which is via the catechol-O-methyltransferase enzyme. These usually break down the epinephrine and norepinephrine, and they break them down into something called norepinephrine, or, so norepinephrine over here would be norepinephrine. And then for the epinephrine, it would be metanephrine. All right? Metanephrine. Over here would be metanephrine. So you see these are basically just the breakdown products of norepinephrine and epinephrine. Now, if a patient has pheochromocytoma, they're generating lots of norepinephrine and they're generating lots of epinephrine, which if there is enough of this enzyme present, it would generate a lot of normetanephrine and a lot of metanephrine. So then these actually are secreted via the kidneys. So if these were actually to be taken to the kidneys, they would be excreted into the urine. All right? So these would then filter in this particular test over a 24-hour period. We would test the test the urine, where these two particular breakdown products should be in higher amounts. If they are 3 times the upper limit of normal, this is a positive test and gives you a pretty strong degree of suspicion that you may have a patient with pheochromocytoma. But if you want an even better test for your high-risk patients, the one that you have a very strong suspicion about, you go straight to the blood. You don't worry about the urine, you go straight to the bloodstream and you sample their bloodstream. So these will move into the bloodstream and then go to the kidneys. Don't waste time waiting for the kidneys. If these are both elevated into the bloodstream, these are 3 times the upper limit of normal, you have a positive test and a pretty strong degree of suspicion that the patient has pheochromocytoma. Now, one quick pearl, I found this to be super cool. Always do this test supine, and while they're supine for at least 30 minutes. It can give you a false positive if you do not do this supine. You know how many times false positive? 3 times the false positive rate if it is not done supine for at least 30 minutes. You need to remember that, because if it's not, they can have a very high false positive rate. Okay, so they have these signs, plus they have one of these positive. Then we have a very strong suspicion this patient's got a pheochromocytoma. If that's the case, I need to localize where the tumor I suspect would be. In 90% of cases, where would it be? In one of the adrenal glands, usually in the medulla. Okay, so what I'm going to do is I'm going to get a CT or MRI of the adrenals, and I'm going to get a good look at them. And what I should find is, I should find an adrenal medulla tumor. So in 90% of the cases, I should find a adrenal medulla tumor. And it should be unilateral. And it should have a benign appearance, and it should usually be in an adult, and it's idiopathic. If it presents near the organ of Zuckerkandl, this is a part of that 10% of cases that are usually bilateral and involving the organ of Zuckerkandl. And generally, this is what we refer to as a paraganglioma. Now, if I have a patient who has the 5 Ps plus they have a positive screening test for the 24-hour urine metanephrines or the plasma metanephrines, one of them are positive or both of them are positive, even better, I get the CT or MRI of the adrenal glands and I find a tumor and it's in the adrenal medulla, I'm done. I don't have to do any more tests. Okay, I've determined that this is likely an adrenal medullary tumor. It's a cancer of the chromaffin cells. It's idiopathic. It's likely going to be some degree benign. There's a chance it could be malignant, but it's unlikely for it to be malignant to some degree, and it's also unlikely for it to be familial. But if the patient has extra adrenal tumor, in other words, that CT or MRI showed that it was not in the adrenal medulla. If it's bilateral, if it is in a child, and if they have a family history of some type of pheochromocytoma, or they have a family history of von Hippel-Lindau disease, or they have a history of MEN2A, MEN2B, or a history of neurofibromatosis type 1, then you need to test them. Then you need to test for which types of diseases? Neurofibromatosis type 1. You need to test them for the von Hippel-Lindau gene, and you need to test them for MEN2A and MEN2B. Okay? This is the way that we would go about determining this patient, okay? So if they have the 5 Ps, they have a positive urine metanephrines or plasma metanephrines, and they're elevated 3 times the upper limit of normal, and then we localize the tumor to the adrenal medulla, diagnosis is done. It's likely idiopathic, it's an adrenal medulla tumor. I don't need to do any further genetic testing, okay? If it's extra-adrenal, if it's bilateral, if it's in a child, and if they have a family history of any type of diseases such as these, you need to test them for that because that could be their cause. Now what we need to do, my friends, is talk about the treatment of a pheochromocytoma. All right, so when we talk about the treatment of pheochromocytoma, it actually comes down to the most concerning feature of it, which is the cardiovascular effect. Hypertension, tachycardia, those are bad things because they can precipitate a hypertensive crisis, which can cause true mortality-based effects. You can end up with a stroke, you can end up with an acute MI, you can end up with renal failure. So there's some significant downsides to having that hypertension and that tachycardia. The cutaneous vessel vasoconstriction, the hyperglycemia, the tremors, things like that, they're not fun, but they're not the most concerning and absolutely high mortality-based factors. So because of that, oftentimes the treatment's really easy. You just cut out the tumor. You remove the tumor and then you ligate the venous supply from it. And then in the interim, you have to control their BP. And really this should include BP and heart rate control. Truly, it should be heart rate and BP control. So the ways that we can do that is we can give drugs, and we have to be very, very careful here. So when we talk about this, we had 2 different types of receptors. We had the beta-1 adrenergic receptor. That was this one here on the contractile portion and on the nodal cells. And then we have over here the alpha-1 adrenergic receptors. And that was here present on the arteries, the vasoconstrictive portion, okay? When we give these drugs, you actually want to avoid giving like pure beta blockers. The reason why is when you give a beta blocker, think about it like this. Okay, here's the way I want you to remember it. The reason why you want to avoid like pure beta blockers is when you have on this artery, you have 2 different types of receptors. Here you're going to have a beta-2 adrenergic receptor, and here you're going to have an alpha-1 adrenergic receptor. When you give a beta blocker, it may block the beta-1 and it may block the beta-2. And that may sound like that's all fine and dandy. But let's say that you give here a beta blocker and it blocks the beta-2 adrenergic receptor. Well, that's great. Epinephrine and norepinephrine can't bind onto the beta-2 receptor, and that's fine. But what it can do is all of it can bind here onto the alpha-1 adrenergic receptor. And that's where it's a problem. Because the alpha-1 adrenergic receptor will then, if it's being excessively stimulated, it'll increase your systemic vascular resistance and increase your blood pressure. If you give a beta-2, or if you give a beta blocker and it blocks the beta-2 receptor, this is supposed to promote vasodilation. Right? So now you inhibit the decrease in systemic vascular resistance, and instead you precipitate their blood pressure to go up even more. So you see how beta blockers can precipitate a paroxysmal event of a pheochromocytoma? That's why we want to avoid giving pure beta blockers, because they produce what's called unopposed alpha-1 vasoconstriction. So what can happen out of this is you can experience something called unopposed alpha-1 vasoconstriction. And the problem with this is this can actually worsen the blood pressure. So you want to primarily give alpha-1 blockers. Okay, that'd be a desirable effect. So what I want to do is I want to give alpha-1 adrenergic receptor blockers. So I want to give a drug that's going to block norepinephrine and epinephrine from being able to bind to the alpha-1 adrenergic receptor. So the drug that I would give then, if it blocked that, it would decrease the systemic vascular resistance and it would decrease the blood pressure, right? What drug would do this? The drug of choice here is called phenoxybenzamine. And the reason why it's the drug of choice is because you can give this one. It's a little bit like easier to titrate and control. You can give this like in an IV form. If it's a little bit more stable, if the patient's a little bit more stable, you can switch them over to like something like doxazosin, right? Or prazosin or terazosin. These are other options, but these are usually when the patient is a little bit more stable. I would stick with this when they're more ill, with the phenoxybenzamine, okay? So this would be the option I would start with first. This is going to lower their blood pressure, okay? When you give the alpha-1 adrenergic receptor and avoid unopposed alpha-1 vasoconstriction. Now that you have a drug hitting the alpha-1 adrenergic receptors, you can now give a drug to block the beta-1 adrenergic receptors. Because you're blocking the alpha-1, you can now give something to block the beta-1 to prevent an excessive increase in heart rate. Because now their heart rate's going too fast. What I want to do is, I want to inhibit the beta-1 adrenergic receptor. And so if I do that, I will lower the heart rate and I will decrease the tachycardia and the palpitations. Right? And this is a great thing. So the question then comes, which drug would do this? The preferred drug to give to block the beta-1 receptor is propranolol. Or you can consider metoprolol. But propranolol is going to be the preferred option. So again, propranolol or metoprolol will be utilized to lower the patient's heart rate. And then phenoxybenzamine will be the agent to lower the patient's blood pressure. We will generally do this regimen for at least 3 days pre-op, and this one for at least 14 days pre-op. And this will bridge them, this will be their bridge to getting a surgery. Because if we sent them right to a surgery, you're manipulating the abdomen, my friends. What would you do? Pump out and surge all these catecholamines that would kill them. So suppress all of that norepinephrine, epinephrine that they're going to experience during the surgical procedure, get them super prepped, get them to surgery, and then once they're stable on these actual therapies, then you can do a tumor resection and a venous ligation. So in other words, you want to ligate all the blood supply coming from the adrenal medulla. And this would generally be curative in that particular scenario. And this would generally be the curative type of effect. So my friends, in this video, we talked about pheochromocytoma. I hope it made sense. I hope that you guys did enjoy it. And as always, until next time.